So we can welcome everyone while they're joining.
Hello and welcome to all participants who are joining this webinar on the resilience of local governments, a multi-sectoral approach to integrate public health and disaster risk management. Just to some guidelines on how we'll proceed. This webinar is being simultaneously interpreted into Spanish. So you can choose English or Spanish and you'll be able to hear accordingly. And secondly, for when we go into the question and answer session at the end, or even before that, if you want to, you can type your question into the Q&A box. So not the chat box, but the Q&A box. Please type your question. And it would be convenient if you could also let us know which speaker this question is addressed to. So today, we have now more than 650 participants from around the world and increasing. Welcome again. We have a good lineup of speakers, commentator, and opening address. So let me first start the session by requesting Mr. Raul Salazar, the head of the UNDRR office, a regional office for Americas and the Caribbean, to give welcome remarks. Raul, the floor is yours.
Thank you very much, Sanjaya, and welcome to all the people that has linked today for this webinar. From the regional office of the Americas and the Caribbean, that is a region that gathers a very large network of cities engaged in the context of the Resilient Cities campaign. I think it is important, it was important for us to highlight what are the linkages of what the cities are doing now, how the cities are facing this COVID-19 crisis, and gather some lessons from there. There is quite a clear message that we are trying to foster, which is basically that prevention saves lives, but the work of prevention has been lacking or have lost sight of this aspect of the Sendai framework that was highlighted also when it was drafted, which is that risk comprehends not only what we are used to, which is basically natural hazards, but also entails how we are going to face, for example, situations like we are facing now, like biological hazards. One of the lessons that we see already happening in the region is how we address these crises, not only from one sector, which is health, but how other sectors that are linked to these cascade effects of the crisis might also be addressed from the perspective of disaster reduction and how the disaster management systems organize themselves to address this type of hazards. So one of the lessons is how we address these multi-sector aspects of disaster risks and how we integrate this into the management systems, but not only from the national perspective, but also from the local perspective. There are lots of instruments from resilience that are coming from the region, from the local governments, and we have seen that through the implementation of the Resilient Cities campaign. And we would like to highlight the usefulness of these tools that are already implemented at the local level to assess, to prepare better, and to save lives in the future. This is basically the objective of this webinar. And then we would like to share with you the experience of distinguished guests that we have as commentators for this webinar, and then try to draw some lessons not only from what has happened, but also how we are going to prepare for the incoming months, for how the cities are going to prepare themselves and contribute to also national efforts. So again, thank you very much for your time this morning. And I hope that this webinar is useful for you as much as we expect it is for us already. Thank you very much and good morning.
Thank you, Raul. And yes, it is very important. This is going to focus on the multi-sectoral approach and how to integrate health issues into the disaster risk management process. Moving on, I'd like to welcome Dr. Jawad Mahjoor. He is the Assistant Director General, Emergency Preparedness at the World Health Organization. Dr. Jawad, please, the floor is yours for the opening remarks.
Thank you very much for giving me the floor, and thank you very much for this excellent opportunity. Good afternoon, good morning, good evening to everyone around the world. Let me first welcome and appreciate the collaboration of UNDRR and WHO in organizing this webinar to discuss pertinent issues in managing the current COVID-19 pandemic. The overarching goal of WHO is to control the COVID-19 pandemic by slowing down the transmission and reducing the mortality associated with this disease. This, of course, requires a rapid scale-up of comprehensive public health measures with the full engagement and participation of all members of society, from individuals and community to local and national governments. Today is a very special day for us, for WHO and for healthcare workers. This is our World Health Day. Every 7th of April, we celebrate World Health Day. And this is an opportunity for us to pay a special treatment to all frontline health workers, particularly the nurses and doctors around the world who are facing, preventing and providing care to patients of COVID. And happy World Health Day to all of you. I'm also pleased to inform everyone that we are launching the first ever State of the World Nursing Report 2020 to highlight the status of nursing and set the agenda for strengthening the nursing workforce for years to come, and also to highlight the role, a crucial role that nurses are playing, not only to prevent disease, but also to provide essential cares to those who are in need. I would like to thank our speakers who are going to take the floor in this gathering, and also to thank all of you for joining, and particularly the UNDRR and my WHO colleagues who are working closely to organize this webinar. I'm glad to note that the speakers will discuss the importance of aligning other sectoral actions to health sectors using the WHO Health Emergency and Disaster Risk Management Framework in the current pandemic webinar, in the current pandemic situation, sorry. The Health EDR framework was launched during the 6th Global Platform of Disaster Risk Reduction last year, and the strengthening capacity of the health sectors and multiple sectors working together. I would like to say here a few words about the current COVID-19 situation. The pandemic is a matter of national and local health security. Health security is bolstered by emergency evidence showing that successful engagement of governments working together with all relevant stakeholders in disaster risk assessment and decision-making will increase the likelihood of precautionary policies and action being implemented responsibly across all sectors in the society. In the rapidly evolving COVID-19 pandemic, we need to strengthen the existing capacity and ensure sustainability to prevent future events. Many of the successes and progress in emergency preparedness that have been made during recent years are now contributing to the management of the current COVID-19 pandemic. And more should be done, particularly in the health system, readiness and resilience. This pandemic showed us once again how much preparedness is critical, only for developing countries, but also for countries with mature health systems. WHO is working very closely with its member states and partners to continuously improve and strengthen these efforts. I would like to reiterate that while doing so, our emphasis is on all hazards, sectoral disaster risk management approach, and by ensuring coherence and comprehensive and complementarity across all action to implement the International Health Regulation 2005, the Sendai Framework for Disaster Risk Reduction, the Sustainable Development Goals, and other frameworks supporting the health emergencies. As of today, last night, more than 1 million confirmed cases of COVID-19 were reported, with more than 67,000 deaths. And these have been enormous social and economic disruption, which are continuing to unfold. The impact is expected to grow in the coming days. I would like to highlight here some challenges for discussion. First one is containing the pandemic and reducing the health impact should also include protection of the healthcare workers. They are the frontline responder to this disease, and we need to protect them by all means. Second, reducing social and economic disruption as much as possible through joint action and maintaining the continuity of society to protect people, physical and mental health and well-being. And here, the role of the intersectoriality and mobilizing all sectors is a key. Third one, while managing the current pandemic, the needs for preparing and responding to to the current and seasonal emergencies and disasters that countries are potentially exposed to. And here also, we need to be vigilant and prepared to face what we may face during the pandemic COVID-19. Finally, documenting good practices and lessons learned from the experience to reshape our future, build back better with better preparedness and resilience. We need to capitalize on all ongoing experience and learn from each other across the world. And this webinar is one excellent opportunity for this. Thank you. Back to you.
Thank you very much, Dr. Jawad. Now I will move quickly to the first speaker. We have with us Dr. Peter Williams, who is the IBM Distinguished Engineer. So Peter, you are going to talk about the public health addendum of the scorecard. The floor is yours. You have to unmute, please.
Good morning, good afternoon, good evening to everybody. I'm Peter Williams. It's my great pleasure to be speaking with you today on the subject of the disaster management scorecard and its potential integration with the work of the World Health Organization. Ben, if you could advance one slide, please. So the public health addendum, as we call it, is a supplement to the original disaster resilience scorecard that the UNDRR published back in 2015, for which I had the privilege of being the lead author. We wrote it to help address the public health implications of major disasters such as floods and earthquakes. That was its primary focus when we first put it together. But it's evident above all now that pandemics share the depth and breadth of impact of other disasters. They're every bit as catastrophic as a major earthquake or as a major flood. Therefore, an instrument that deals with the kind of impacts that a flood or an earthquake can have right across the system of systems, if you will, that makes up a city may prove useful for dealing with a thing like the coronavirus, and indeed other pandemics that arise in the future. It may prove helpful in enabling people to think through all of the implications beyond just the healthcare system, but that ripple out to the other systems within which the healthcare system is embedded and the other systems on which the healthcare system depends in order to operate. So what we're going to do, we're going to cover, myself and Ben Ryan, who will follow me. We're going to introduce the city scorecard very briefly, just to explain what it is. We're going to talk about the public health addendum, and then we're going to talk about how the scorecard might actually be used in resilience planning, disaster resilience planning, disaster risk management reduction. Ben, next slide, please. The disaster resilience scorecard was originally, I said 2015, I misspoke, 2014, was put together by a team from IBM and AECOM. At the request of the then UNDRR. It takes the UNDRR's concepts of the 10 essentials, which I'll come back to in a minute, and breaks them down into a series of measurements. The short form of the scorecard breaks them down into 47 separate measurements. The long form of the scorecard breaks them down into about just over 117 measurements. Each of those measurements are scored through a kind of a self-assessment process, and the summary result is the Euler diagram, or as it's sometimes called, the spider diagram that you see on the slide here. It allows a city to understand where it is strong, where it is weak, where it needs to devote time and attention to improving as it goes forward, and where it can where it needs to allocate its funds as well. It's now been used by around about 200 cities around the world. It's also been used by the European Union as an adjunct to its Resilience critical infrastructure project as well. It's been translated into 13 different languages, and it can be downloaded for free. It's in the public domain from the URL that you see written there. It's also worth noting that there is a further version of the scorecard that we've literally just published in January this year for industrial and commercial real estate. And that is also available from the URL that you see there. Next slide, please. Very important to understand the frame of reference that all of the scorecards and the public health addendum actually take. And if you will, envisage a spectrum that runs from chronic stress on the one hand through to acute events on the other. Chronic stresses could be environmental, economic, social, cultural, and acute events are the actual disasters and for whose risk we're trying to plan. The critical point is they interact. People often say, what is the difference between disaster resilience and sustainability, for example? Well, environmental stress can predispose an area to a worse natural disaster. For example, where an area has cut down the trees on a hillside, that might increase the risk of flash flooding. Or conversely, chronic stresses like economic stress can hinder recovery from a disaster. And we're surely going to see that after the COVID pandemic. Some societies are going to get over this better than others. And that's a function of economic, cultural, social, chronic stresses. So you have that interaction between the two, and that's very much the frame of reference that underpins all of the scorecards. Next slide, please. The original 10 essentials are, as you see here, they have the great benefit of being holistic. They provide a great coverage of the field for disaster resilience and disaster risk reduction. I used the term earlier, the system of systems. They allow the system of systems in a city to be addressed holistically, whether you're talking about technological systems, social systems, economic systems, and they're great for making connections between them. I've done many workshops with the scorecards, and almost always something comes out of those workshops for the participants that none of them had expected. Somebody has a conversation that they should have had years ago, and as a result, that city is able to become more resilient. So they're a great construct. They work exactly as they were intended to work in terms of covering the whole field. The one thing against them, we would say, is that the public health issues attendant in disasters don't really emerge very clearly from that structure. And that's why we created the addendum to the scorecard specifically to address public health. Next slide, please. This is just an example of the scorecard so that people can see what we mean. The indicator is the second column from the left, and the third column, and then the area that it actually addresses. Each measure has an indicative measurement scale. This is from the long form, so it's 0 through 5, and then there's a commentary in the right-hand column. This is basically the structure of the thing. This is also the structure of the public health addendum as well. And I just wanted to show an example of the structure there. Next slide, please. In applying the city scorecard, as the Making Cities Resilient Report 2019 showed, there are some very consistent themes that come out. And these are relevant to pandemics, just as they're relevant to floods, earthquakes, wildfires, or whatever. The first is that Essential 3, which is the financial capacity, is rarely sufficiently addressed. You frequently find cities wringing their hands saying, we can't afford possibly to do all this stuff, but they haven't investigated all the possible sources of finance, whether from the public sector, private sector, NGOs, foundations, whatever. They need a financial atlas of where to go look for money. And if UNDRR and World Health Organization really want to do cities a favor for future pandemic planning, they could start to create that financial atlas. Where in the world, from what kinds of organizations is funding actually available to improve resilience to pandemics? We find that Essential 7, which is societal capacity, social engagement, community engagement, tends to lag behind. People tend to think that it's a one-shot deal. In other words, you just sort of send out a few messages and there you are, you've got the community engaged. Not so. It's a lifelong process. It's a continuous process. It has to be worked out over and over and over again. And very few cities, relatively few cities, fully understand that. And then essential number 10 as well, which is also the proverbial build back better, which everybody talks about. It's actually it is very easy, in fact, to think about some aspects of how you would recover from a disaster in advance of the disaster, and relatively few cities actually do that. So those are some patterns that have emerged. Other trends, which I guess I would add from my experience in working with cities around the world on this thing, the full economic impact of a disaster is rarely understood, and this will be true of COVID-19, I'm quite sure, until you've actually been in one. And people don't realize that, you know, it is entirely possible to shut down an economy with a disaster and the implications of that. There is a very clear pattern that we see. Many cities are what I call tactically strong, strategically weak. In other words, they're really good at making up responses there and then in the moment, just as we are with the coronavirus right now. The strategic thinking that needed to have gone in beforehand, on the other hand, is much more of a problem. So tactically strong, strategically weak. Community engagement also needs to include businesses. Businesses are part of the community, and the community works for those businesses oftentimes as well. So community engagement needs to include business engagement. Critical asset management is what I call the forgotten hero, or sometimes the villain of disaster management. And you can see that in the context of pandemics, the shortage of masks, maybe masks should have, with the benefit of hindsight now, have been designated a critical asset or a critical supply. In many places, they clearly were not. Ventilators, similarly, as we're finding here in the United States right now. There's too much reinvention. There's too much not invented here. There's not enough attention paid to learning from elsewhere. There's not enough of an exchange of ideas. And as I said earlier, the discussion with the scorecard is always as important as the score. Simply getting people together in the room and having them share their assumptions and what they're expecting of other people, and identifying the mismatches so that action can be taken from that point on to address them. So that, as I say, the discussion is always as important as the score. Next slide, please. So let's come now to the public health addendum. As I said, it was created to address the one obvious weakness in the 10 essentials. It uses the same 10 essential structure. In the context of a pandemic, it focuses on the wider issues of management of the pandemic and recovery from it. I do stress it is not a medical tool. It is not an epidemiological tool, although clearly those disciplines are going to inform the answers that you give when you're completing the scorecard. The graphic at the bottom is simply to illustrate really the number of different dimensions in the healthcare system of systems, how that embeds in the city system of systems, and the number of different connections that actually need to be made. I'm not going to stress that at length. Next slide, please. Some examples of what is covered in the healthcare addendum. Under essential number 1, which was organisation and governance, it's about asking are the right people in the room, are the right professionals involved, are other professionals, let's talk about sanitation, water, energy, communications engineers, are they involved in public health planning? Because if they're not, those systems are going to be missing when the public health system needs them. Number 2 is about risk understanding. Are pandemics included in risk management? Does planning include the impact of pre-existing chronic health stresses, malaria, malnutrition in some parts of the world, alongside, let's say, disasters as usual, if I could use that expression, floods and earthquakes and fires? Always the issue of combined disasters. Here in California, where I live, we're just now turning our thought to the idea that, well, if we've got social distancing going on, how's that going to play if we have a bad wildfire season and we have to put people in fire shelters where it's going to be impossible to exercise social distancing? What's the interaction there? How do we manage that? The financial architecture I've already discussed. Cities don't know where to go to look for funds, and they don't protect the funds that are available. And in ever so many countries around the world, you're hearing stories of funding and such that had been allocated for public health having been siphoned away over the years, and now all of a sudden cities and countries are scrambling to catch up. So the adequacy of funding, the protection of that funding. Essential number 4, land use and building codes. If your key hospital is at risk of being flooded, and Ben has a story which he'll tell about that from Australia later on, your pandemic preparations are deeply suspect in the event that it should happen to rain. Ecosystem services, what ecosystem services are there with health benefits and so on. So natural water filtration, tree cover to reduce urban heat island effects, that kind of thing. Capacity, which is basically the availability of the right skills, both medical skills and other skills, and the availability of the required data shared with and between other stakeholders. Social capacity, which is, as I said earlier, community engagement, community trust of the information provided, which is a big issue in some parts of the world right now. I notice in some parts of Africa, for example. Community mental health and mental stress management, so social capacity. The infrastructure, the healthcare infrastructure itself, how resilient is it? Key features of that infrastructure, all of the different kinds of buildings, all of the different kinds of physical equipment and plant and so forth. What's the surge capacity? What about continuity of care for those who are already sick? How is that likely to be taken care of? Then your actual disaster response itself, the early warning systems, the integration with emergency management, education, rehearsal, drills, public health supplies, and so on. And then finally, as I mentioned earlier, recovery planning, offsetting the long run impacts on health, learning and improving so that next time around you do it better. So those are some examples of what is covered in the healthcare, the public health addendum. Next slide, please. What we've now done is try to show how this can be linked to the World Health Organization's emergency and disaster risk management framework. Its core principles are a risk-based approach. It likewise seeks to be comprehensive across prevention, preparedness, readiness, response, and recovery. It seeks to take an all hazards approach. It certainly seeks to be community-centered and operate at sort of community and national and intervening levels as well. It is focused on the entire health system, and it also has a strong component of ethical considerations as well. So in that sense, it's highly compatible with the Disaster Resilience Scorecard and the Disaster Risk Management Framework from UNDRR. Next slide, please. So I just produced here a cross-reference. I'm not going to go through this in detail, but I just tried to identify the World Health Organization framework components and how they map to the UNDRR 10 essentials of disaster risk management as well. So there is a reasonably good match all the way through. I'd be more than happy to discuss this offline in more detail and how it might further match up. Next slide, please. And Ben, I will now hand over to you, and thank you very much.
Thank you, Peter.
Thank you very much, Peter Williams. Now let me introduce Dr. Ben Ryan. He's a professor at the Baylor University in Texas, and we'll be talking about the applications of the scorecard health addendum. So Ben, the floor is yours.
Thank you, Sanjaya, and thank you, Peter, for your presentation. So what I wanted to set the ground for here is how we can get ready to implement this scorecard. So there's a cycle here where we can organise, prepare for disaster risk reduction, and then we've got local resilience assessments, which we're rapidly doing that globally now with the COVID-19 pandemic. Then we can develop strategies and action plans, and that's really the phase we're starting to move into globally on how do we recover from the COVID-19 pandemic when it ends. And then we think about implementing the strategies. Then we need to do some monitoring and evaluation. So this is a complete cycle that if we implement this, we can start to have more resilient cities for things such as a pandemic and any other disaster you may face. So there can be the 5 phases here, but on the right-hand side in this matrix, you can see there are 14 different steps that can be created. And I would suggest now we have the institutional setting and awareness of the need to have this planning in place for a pandemic. So you can start moving through this phase approach to help us come up with a really good recovery strategy. And I think the scorecard provides a really good tool for us to do this, particularly in a rapid manner with the current situation we're in. You need knowledge of your public health system capacity, stakeholders, and we're starting to get to that point collectively as we are involved in the COVID-19 pandemic. Understanding your public health infrastructure. So this includes supply chains, transport companies. So our public health system is not successful without all the different factors. So it's multi-sectorial. We really need to highlight that for us to be effective as a society in providing good public health services. We need to consider a whole of society approach. We've got data on healthcare outcomes, so we need to understand what that may look like, including vulnerable populations. We're getting more information on who may or may not be more vulnerable to COVID-19, so mapping and understanding those needs. And then also a system where you can get the experts, but also the committee collectively working together. And this can be at the local emergency management committee level to really help enhance preparedness and response strategies to disasters and pandemics. An example of this was in Tonga. In this scenario, you could really see a multi-sectorial approach. This was prior to the scorecard and has helped us develop the scorecard to where it is now, and really highlights how this is a multi-sectorial approach. So water scarcity was a big issue, and I've highlighted there that was affecting people's health. And this was identified through community consultations, and water supply was top priority. And this is the beauty of this framework or this scorecard, is we're focusing on what is it that the community needs to function. So it's really community driven. And what they wanted was site selection, safe access for women, for example, and persons with disabilities. So this is reflecting local community needs. This ended up being part of the Ministry of Finance and the National Planning to focus on community needs and priorities for disasters, but in this example for water scarcity, because that is also a disaster that's facing potentially many nations around the world. And that links into Essential 2, which is to identify, understand and use current and future risk scenarios. And then this is a case study, I think a gold standard case study of public health system resilience. As there's more and more disasters, we're really getting better at preparing and responding. And we learnt from this, for example, in Cairns in Australia, where we had a large tropical cyclone. It was actually the largest cyclone across the coast of Queensland. And as a result, in preparation, we needed to evacuate patients down to Brisbane, which is about 1,700 kilometres south by road. So people got evacuated. And then there was a temporary emergency medical shelter for 28 hours. And then what was really a really good sign, I think, of good leadership is when you're prepared to evaluate your response and learn from it. And this is what local leaders in Cairns and also through the Queensland government and community leaders were prepared to do. And you can see here the Premier, which if you're in the US, that would be a governor. So at the state level, there was a health review. So what we identified is that we had this wonderful hospital facility in place, but we identified that storm surge or tidal inundation from a cyclone was a real risk. We engaged with community experts, did assessments around community, again, focusing on community needs and desires. And what we're able to do working in a whole of society approach is come up with a purpose-built facility called the Cairns South Health Facility that could withstand a Category 5 cyclone, was outside storm surge area, had a helipad. So what the assumptions we had made here is if, for example, we had a storm surge, that worst case scenario, as a community, we were prepared to fill in and continue to provide emergency medical care. So I think this is a gold standard case study of how this type of approach can be applied to your different community needs and priorities. It also can be tied into the finances or funding you may have available, because disaster risk reduction, even pandemic risk reduction, doesn't need to be expensive. If you get everybody in the room from different sectors, you can come up with these creative solutions that are within your means to prepare and respond to a disaster. Another great example is in Cox's Bazaar in Bangladesh. We had people placed in settlements in extremely congested areas. Again, this was pre the scorecard, but I just wanted to provide an example of how it could assist. There were access to basic infrastructure services, This area is prone to natural hazards, especially cyclones, floods and landslides. And Bangladesh is a country that's very subject to these types of events. So an assessment that was undertaken identified that we needed to look at improving disaster risk management, healthcare, education and emergency response. So then this triggered health sector support. And as a result, there were mechanisms created to respond to potential health risks that may emerge, such as cholera, diarrhea, and then there was vaccine programs that were starting and campaigns starting to come in with specific diagnosis and treatment services. So you can see here on these three examples, we've got all different types of nations that could apply this to suit their challenges they face and direct it at the community level. And that aligns with Essential 7, so understanding and strengthen societal capacity for resilience. Now, within the scorecard and what's relevant to the pandemic and disease outbreak, and I would propose this could be rapidly applied right now. You could have, for example, local emergency management committees could systematically go through this process, and there's 12 indicators that are directly relevant to a pandemic or an outbreak. So this could be disaster risk planning, includes public health and emergencies. I think we can tick that one off now. Consideration of public health impacts arising. And then you can see A6.1, sufficient skilled health professionals to maintain public health around disasters. So this is doctors, nurses, but most importantly, this is highlighting a whole of system approach. There's a lot of support that goes in behind to get doctors and nurses on the front line. That needs allied health professionals, pharmacists, environmental health, epidemiologists, supply chain managers, and laboratory technicians. So we need to have all these aspects of society ready as we get ready to move into the next phase, and particularly identify perhaps when it's safe enough to start considering when do we ease some of the protective measures that are currently in place. Then A6.2, public health data should be shared with all stakeholders that need it. So what we can do now is we're seeing where the data is coming out, where decisions need to be made around, for example, COVID-19 pandemic. But what we can see is as we get ready to recover and maybe lift some protective measures as things start to look better in the future, we need to also monitor the data so that we can implement those measures again if the strategies that the community came up with weren't working. So this is why the scorecard can be really helpful now, but also in the future. But most importantly, it will generate the discussions required to make sure you have a whole of society response to, for example, COVID-19. And then A7.1, communities are prepared to maintain public health levels after a disaster. That will be a very important discussion as we get ready to recover. A8.2, health facilities can manage a surge of patients. So we really need to understand, can the health services deal with a surge of patients? And we need to model what those are as we get ready to recover from COVID-19. But this is also vital for other disasters, because when I've worked in health systems, we would often try to model what is the likely surge of our patients, but then we would also think about what's the likely capacity of our workforce and also our supply chains and all the auxiliary services that are required to maintain the health system. And this, by taking this approach, you can have a multi-sectorial mechanism for supporting pandemic or disaster risk management. So disaster risk management is an all hazards approach. And I'm just highlighting the current pandemic as a real life example to take you through this that we're dealing with right now. But you can see down the bottom, we have the Making Cities Resilient campaign. If you have that implemented, you need to be aligned with the WHO guidance on health emergency and disaster risk management, have completed the disaster resilience scorecard for cities, and then you involve or integrate the public health system resilience scorecard. You are then in the best possible position you can be from a whole of society approach to deal with any sort of disaster that may occur. And the most important thing is you're identifying and assessing risks that you may or may not live with, and you're identifying what your responses may be to those risks. So how do we move this to action? This must be locally led and developed. It can help cities establish their public health system resilience baseline and can help frame an action plan. And it will that will complement different strategies that are already in place. So you've got the Rockefeller Foundation with their Cities Resilient campaign. So this would align with their campaign as well. So we start at the local level. For example, in a lot of nations, you'll have the local emergency management committee. You will then go to your district or region, and then you come down to your state and province, and then national level. So you do this at the local level, and if health services are doing this or communities are doing this, they can then go to the region, which gives you a really good regional oversight. And that example I used in Cairns would follow a systematic process. This is prior to the scorecard. We're able to escalate what we identified as our strengths and weaknesses to the district and region. And they were happy to know that we had done that so they could plan accordingly. If we hit a certain threshold, they knew what was required. And this also aligns with a whole of society approach. And an example of how this can practically be implemented is through, for example, your local emergency committee. Every nation or most nations around the world have a local emergency committee. This includes elected officials, utilities, so your water, telecommunication companies, internet companies, media, emergency management, community groups, and industry. Industry is vital because most people work in industry, and before a disaster, for example, supermarkets are operated by industry. So we need industry at the table, law enforcement and fire service. So under this model, no agency is more important than another. Some may be leading the certain responses, for example, in public health, it's health that are leading it. However, you're getting input from all different sectors. And in this current scenario, what you could have to apply this scorecard, you'd have your local health leaders, so your member on the emergency planning committee, and that's the type of role I've had the privilege of working in before. And then you can work in with emergency management. And together, you could potentially table this as part of your local emergency planning committee meetings. And how this could be implemented, for example, as I live in Central Texas, I thought using a Texas example, which I'm familiar with, would be good. You could, for example, apply it locally where I live in Waco, Texas. You could then escalate that up through the disaster districts they're called in Texas. Every state, every country is different. There might be, you might go straight to your state or something like that. So you go to your relevant region within Texas. And this is completely aligned with the disaster management arrangements. And if we've learned anything over the years with disaster systems, we need clear command, control, and coordination. And we can apply this scorecard, this public health scorecard, within that system by ingraining this within the local emergency management committee and escalating it accordingly. And then from a US example, if you did that at the Texas level, you could then feed that into the Federal Emergency Management Agency, which is FEMA. And then if you had all your cities and communities and counties doing this across a nation, you could then have your districts fully aware, then your state's aware, and then it goes to your Federal Emergency Management Agency. Then you have all of a sudden national oversight of your public health system resilience. And the fantastic thing is you can identify your strengths and weaknesses, because it's important to know both of those during a disaster so you know where you need to allocate your resources. So the benefits of the public health addendum, it's far beyond the reporting. It's really the conversations that are generated. And again, in a health system where I've worked, through these discussions, a systematic approach at the local emergency committee meeting level and working with experts in that area, we were able to identify for one hospital, the greatest risk was a sewage pump station that was subject to flood. So initially we were thinking there was all these other risks for the hospital. If we lost our sewage system that services the hospital, that was going to be a great risk. So then what happened is we reinforced the sewage pump station. These are the fantastic discussions that come out that you will not see these if you do not have these discussions in the time of a crisis. And Peter mentioned the face mask. If we have this whole society approach, they're the types of things we could identify before a pandemic or a disaster as priority needs. It also establishes a baseline measurement. So you could do this every few years to track your different priorities. And then if you want to get started and get ready to implement this, visit this website. It is publicly available. I'd encourage you to download it. It's This could be rapidly and quickly applied for the current circumstances we're in, but most importantly, would be applicable for an all hazards approach to future disasters. And we'll have the presentation shared after this or publicly available, and there's a link in there where you can go and download that scorecard. Thank you.
Thank you very much, Ben. Now, moving ahead, we have Dr. Rajiv Shah, professor at Keio University in Japan, and he will be providing some comments. And after this, we move into the Q&A. So, Dr. Rajiv Shah, the floor is yours.
Thank you very much, Sanjay. Well, as the WHO ADG has pointed out, today is the World Health Day. Let me start with a big appreciation to all the frontline health workers who are currently fighting for the COVID-19 and beyond. Let me also emphasize, I have a few quick points. Let me first emphasize that when we say the pandemic is global, but its response is very, very local. And this response is very much dependent on the local governance, the local law or regulation, the capacity at the local level, its culture, risk perception, and more importantly, the citizen behavior. Today, several hours ago, Prime Minister Abe of Japan, he declared the national emergency in 7 prefectures, including Tokyo. And when you talk about a national emergency in Japan, it's quite different than what we usually see the lockdown situation in most of the countries. Here, by regulation or by law, you cannot force someone to stay in their home, or you cannot force the shops to close down. You can only request, and I think that's possibly, you can only request to that and the citizen behavior, or you can encourage the people to stay in their home. So my first point is that when you talk about this pandemic issue, the first point we need to keep in mind, this response are very, very local, and locally cultural situations are very, very important. The second point is when we think about both our previous colleague, Peter and Ben, they have explained both the HEDRM, which is the Health Emergency Disaster Risk Management of WHO last year, and also this resilience scorecard and the health addendum. So I will not go into the details of that, but one of the key things which we possibly see in the current situation in COVID response, that possibly in most of the countries, the whole healthcare system actually failed. And one of the key reasons possibly is we didn't have the proper scenario in place. So I would like to underline the importance of local scenario planning, which our previous colleagues also pointed out, and which is also very, very important part of this scorecard and the health addendum, that how we make the future scenario based on proper data. And there possibly one specific expertise is not enough. Yes, epidemiologists possibly will give you the idea that what will be the future growth, in which clusters and so on. But we also need a very strong involvement of other sectors, whether it is the healthcare, the system, or whether it is the risk communicator, whether it is the financial resources, then of course, other monitoring and evaluation specialists. So I think this multi-stakeholder planning at the initial stage, that's very, very important. And what I was thinking that when we do the climate projections, and we always say that the downscaling of climate projections at the city level is always a major challenge. Those who are the climate modeler, they know it very well. But I think for city level, these projections of the pandemic, especially on the downscaling, is more efficient than the whole national level, because at the city level, we have more data, we can also identify the clusters and so on. So there, this whole risk scorecard can play a very, very important role. And that's my point number 2. My third point is what we see is in this overall scorecard, It has both the structural part, it also addresses the non-structural and the functional part. One of the key important issue which possibly we will be facing in next few months, the cascading effect of other disasters. In 2011 in Japan, we have seen that how an earthquake-induced tsunami has actually made this nuclear meltdown. So, and it has a very long-term impact. We are still suffering from that. So in different cases, like in many parts of Asia, the hot summer is coming up. Then in many parts of other parts of the world, there will be the typhoon season. And of course, the other geological disasters or geological hazards are always there. So how we actually incorporate again these different types of other multi-hazard risk into the future scenario planning, I think that's also very, very important. And there, again, the scorecard can play a very important role. And my final point here is I would like to emphasize, or I would like to draw your attention of this particular word, which has been used quite extensively, this infodemic. At the initial stage, we heard that the information, the right information from the right source is very, very important. And there you have heard Ben talking about this community part of it. And there are three specific elements which needs to be highlighted. One is effectiveness of public health system and community engagement. Then communities' access and trust on public health information, and then communities' ability. So in this whole process, I think the risk communication, risk perception, and risk-informed behavior of the communities becomes very, very important. And when you talk about the pandemic, I think ultimately it's the citizen behavior which matters very strongly. So, and that is very much related to how people perceive the risk and how the proper information is flowing, the right information is flowing in the right direction. So I would like to highlight on that particular issue or challenge of this infodemic or the information sharing during this pandemic. With that, thank you very much.
Thank you, Rajiv. So now we have a few questions. We have a lot of questions. We had almost 1,000 participants, but let me just summarize some of them quickly, and I will allow any one of the panel to speak on them. One question is, can this scorecard be used for rural areas as well, the health one? So anyone who would like to answer that?
The answer is yes, it can. Yes, it can. You have you absolutely have the same system of systems kind of effect in rural areas. It looks and feels a bit different, but yeah, it absolutely can.
Okay, thank you. Thank you, Peter. There's a specific question for Ben. The entire process of building resilience at the local government level is quite a lengthy process. How can we speed up, especially when facing a pandemic? So this is for Ben, but Peter or Rajiv, anybody can also intervene. Over.
Thank you, Sanjaya. That's a very important question. I've been privileged to work in that type of role and be part of a Making Cities Resilient campaign using the disaster scorecard. And yes, that does take a long period of time. But what I would suggest is, with some of my thinking about how this would approach it, and this all depends on how well your committee knows each other and can trust each other and engage. That really measures your preparedness and community engagement. I would suggest you could probably have this done within a 2-day time frame if you had the committee together, because there's 24 indicators to go through and you need to collectively go to it. And if you're focused in on it, you can then come up with what I would see as your priority areas to move forward the next few months, because we need to think about that pathway. So I would be suggesting you could do this over a two-day period. Maybe quicker for some other different committees and maybe a little longer for others, but I think I would initially allow 2 days to complete it.
I'd second that. We had a workshop format that we use with a number of cities. This is for the whole city scorecard, not the public health one. And yeah, 2 days was about the ideal. I can actually share the sort of agenda for such a workshop as well, if anybody is interested.
Okay, thank you very much. There are a couple of questions regarding the indicators in the scorecard. So one is, can you explain a bit more on the societal capacity aspect that is in the scorecard? And the other question is, what are the assumptions which are made before using the scorecard?
Right. So I'll take the social indicators one first. The social capacity is basically a function of whether the community is ready, willing, and able to do what it needs to do, given the inevitable limitations on what a city government or a state government or a regional government is going to be able to do. In other words, does that community understand what is going to happen? Has it made the necessary preparations for what is going to happen? The best example I've ever seen of that is a city called San Francisco in the Philippines, where in the aftermath of Typhoon Haiyan, people may recall that the city of Tacloban was seriously damaged and there was significant loss of life. The city of San Francisco, I think I'm right in saying, is about 100 miles or 100 kilometers away from Tacloban. They had similar level of property damage. They knew they would. No single life was lost. And that was simply a function of the fact that the mayor of San Francisco, a chap called Al Arciano, was just one of the most effective community mobilizers, community educators, community engagers you could possibly wish for. And it's simply a function of preparation. So the whole of Essential 7 is really about, is the community ready, willing, and able to do what it has to do? And that's a great example of it. And I'm sorry, Sanjay, what was the second part of that question? What are the assumptions that need to be in place beforehand?
Yes, assumptions.
Yeah, none really. Get stuck in. Try it out and see. I suppose you might say there needs to be, you need to have the right people in the room to complete the scorecard. Usually you're never going to have everybody. There's always one holdout, whether it's the local energy company or the local police force or some city government department. There's always somebody who thinks they don't want to do it, but go ahead anyway and understand where the gaps are, understand where you've got common ground, understand where your assumptions don't necessarily mesh with somebody else's assumptions, and figure out where those discontinuities, where those inconsistencies are. And when you've got that, you can then start to plan around them. You can then initiate the discussions necessary to make sure that everybody is working on the same basis, planning on the, planning in the same way, and, to use a vernacular expression, they're all on the same page.
Thank you. Dr. Jawad, there is a question for WHO. Does WHO not use a standard policy to regularly update the WHO national guidelines? And has this been regularly updated? Dr. Jawad.
Yes, thank you very much for the question. Yes, the short answer to the question, yes, we work closely with our UN partner and other partners and with our member states, not only to provide them with the technical guidance, but also to keep these guidelines updated. And also in some countries, with some countries, we also help in implementing this guidance, and especially in countries who need WHO and other partner assistance. Yes, the short question to you, a short answer to the question is yes.
Okay, thank you very much. There is another question. Please explain how the scorecard measures resilience to pandemics and compare in comparison with the indicators for other disasters such as floods. So how is it different? How is different in the way it measures pandemic or health emergencies as compared to, for example, floods? Maybe Peter?
It uses the same set of indicators which have been deliberately designed to be generic. So the way the process would work, when you complete the city scorecard, essential number 2, you have to determine which risks apply to your city. And now in some cities, that's going to be earthquakes. In other cities, it's going to be floods or coastal storm surge or hurricanes. Maybe in some places, it's going to be a combination of those. I would suggest that every city now using the scorecard also needs to include pandemic as a risk. I can tell you a great many of them don't. But once you have included those as a risk and you've constructed scenarios for what might actually happen, What is let's say a moderately disastrous situation, if you'll forgive the expression, as opposed to an absolute worst case disaster. You've got those scenarios. You can then plan for the impact of a pandemic in exactly the same mode and fashion as you would plan for the impact of an earthquake or a flood. Clearly, the inputs from the public health community will be different than if you're talking about an earthquake or a flood, but the steps that you go through and the structure of what you need and the governance of what you need and the issues around securing funding and securing community engagement and so on, those are highly analogous for pandemics as opposed to anything else.
Okay, thank you very much. There is a question for Ben related to communities' post-epidemic reaction to maintain public health. How can this be done effectively, checking water sources, alerts, etc., without inducing a certain paranoia and creating trauma? Ben?
Thank you. That's a very good question. So I'll just go back to the scorecard initially. I think what you'd need to be doing post-pandemic where we are now, to be in a systematic way to make sure we don't miss anything, is I would encourage you to go through this scorecard, even in a rapid method, so you can work out the whole societal impacts. And that could be food supply, water supply, sewage supply. And there's different people you'll get around the table. For example, you'd have environmental and public health specialists that focus on that population-wide impacts. And in the US, actually, they're the second largest public health workforce behind nurses. So you've got this expertise that you could use. They're also engaged in the local community, so you can use them as a voice to get out to local community members to reduce any paranoia that may occur and ensure the facts are shared. And I think that's one of the beauties of being local, because if this is community focused, people are hearing from the local people that they used to see before lockdowns at the local baseball games, sporting events, at the shops. And I think it's really that community trust and education. And that's why this is such a wonderful process to engage that local community level, so you can reduce the impact of that trauma. And then I'd highly encourage you embrace your communications expert to have a strategy. And that's part of this process. You could come up with a communication strategy that could mitigate any possible paranoia.
Okay, thank you. Dr. Joab, you are seeing the questions in the Q&A box. Are there any comments you want to make regarding those questions or comments?
I saw one question about the supply and procurement of essential goods for the COVID-19. As you know, this is have been very challenging process because the increase of demand on PPEs and other essential goods. We are working closely with all UN agencies to work together and to bring our comparative advantage and together to overcome these challenges, starting from the markets and ending by the how to deliver these goods to the countries, which is a very challenging process, especially with the all travel restriction that now they are taken during this COVID-19. But we guess that bringing our comparative advantages and our forces together, we will overcome these challenges and we'll be able to regulate the market, but also to provide countries who are in need with essential supply to fight COVID-19. Over.
Okay, thank you very much. Peter, there have been many comments regarding the workshop agenda that you had suggested, that there are many who are very much interested in receiving that. And I think there is a comment that often the health systems or the health sector is not part of the disaster risk management planning process. So how, I mean, though the scorecard, of course, advocates for that, how can this be overcome? Any ideas from any of the speakers?
Yeah, absolutely. It's there needs to be a strong relationship between the health system in an area, whether that's a rural area or a city, and the emergency management function. If that relationship doesn't exist, pick the phone up, start talking to them. You know, at some level, it's a human connection between somebody in one of those systems and somebody in the other of those systems. And once you've got that human connection, you can then begin to have the conversations that you need to actually fill in the gaps. But yeah, whoever said that is absolutely right. The health system often is not included, and it should be. And you know, the way to do that is through conversation, through meetings, through interactions, exactly as Ben was saying from his experience as well. Pick the phone up, start talking to people.
Yes, and I'd just like to add to that as well. There probably couldn't be a better time now for health to be engaged as part of the local emergency management committee. And I'd be very confident that if you contacted your local emergency management committee, they would probably embrace and welcome your participation right now.
Yeah, I think that's exactly right. I mean, you know, never waste a good crisis. So you've got one, go for it.
Okay, thank you. I think we are really near the coming to a close. We are over time now. But one last question. You know, how can the scorecard help address transboundary issues? Because, for example, between one city boundary and the other, or one country to another.
Absolutely, and one of the areas that one of the issues you're going to find is where you've got a large urban area that's divided into separate municipalities, and we've done this. I've worked in that situation a great deal. For example, in Florida, where I was working with a group of water agencies who all had different assumptions about sea level rise. So it was kind of like there were going to be steps in the Atlantic Ocean as you went from from one water utility to the next water utility. And you have to bring them together and say, guys, there's a discontinuity here. This is not going to work. What do we do about it? And that's down to your facilitation and your ability to bring people together. Transnationally, it could be harder still. But at the end of the day, if you recognize that you have kind of a shared destiny with some other area, and you'll have a shared fate in the event that there is a disaster or a pandemic or something like that, they have an incentive to work with you just as you have an incentive to work with them. It's not like the pandemic is going to stop at the national border. As soon as you start pointing that out and say, you know, we're probably going to be better off working together, you've got some chance to achieve that. I know that's easy to say and hard to do, but really that is the essence of the process. It's about realizing that you've got a shared fate. What are you going to do about it?
Okay, thank you. I think now we are near the end. We have covered many of the questions, not all, but for all the participants, I'd like to let you know that the PowerPoint and the recording will be available. And when you close this session, please do look at the survey, because in the survey, we are asking you ideas about what the next webinar should be on. So you give your topics to us and then we will be able to arrange that. So please do look at that survey. Before we close, I would like to request Dr. Joad Mahjoor, Assistant Director General from the World Health Organization, to give the closing remarks.
Thank you very much. And let me first contribute to one of your, because I think this is a key element. If there is one conclusion that we need to take from this COVID-19 pandemic, is that there is no emergency preparedness who doesn't look to the health system preparedness. Our health system very often they are not prepared, they are not resilient to cope with this kind of event. We have been working with health system partners for 1 year now to define what are the components of the health system that they will ensure a level of health security everywhere. And we know them. And now we will come with clear guidance to support countries to start to work on them. And we believe that these are the basis of any health system who aim to ensure universal health coverage. Health system should start by this function. surveillance, a good level of healthcare worker prepared to deal with emergency, and also some key healthcare functions like IPC and like others. This is now. Let me, to conclude, quickly thank all of you and also the speakers for their participation in this very important and timely session. From my side, and I'm sure my team was connected, my colleagues, we learned a lot from this debate, and definitely will take many ideas to improve our support and our work. Of course, the resilience of local government and communities is key to, for integrating public health and disaster risk management approaches during pandemic. And this is more important when we come to cities and to urban setting. I think here also, because of the previous outbreak and epidemic, we focused heavily on the rural area, because the epidemic that we were facing, like Ebola, like cholera, like yellow fever, are more epidemic that we see in rural areas, and urban setting should have more attention. We are working also in this area with partner to come up with guidance how to make cities and mega cities prepared, not only to deal with this kind of event, but to prevent them from the beginning. Consideration toward resilience would involve three duties: the duty to plan and be ready, to trace, test, and treat people, to safeguard all peoples, and especially healthcare workers, the frontliners, who are paying a big tribute in the world from this pandemic. Of course, WHO and its partners are continually issuing and updating the technical guidance on COVID, but not only, emergency preparedness as well, and we are sharing this with all stakeholders. And while we are learning from this pandemic, we are updating our guidance to adapt them to this situation. We are also focusing on need for health system to be able to provide routine healthcare services and maintain capacity to surge and meet increased demand during an emergency. Again, because of the interest of time, I will stop here. And again, thank you very much for the speaker, for all participants, the more than 800 or 900 participants who participated. And of course, we are ready to contribute to any future interaction. Thank you very much for you.
Thank you very much, Dr. Joad Mahjoor. Also, I would like to take this opportunity to thank the speakers, Dr. Peter Williams, Dr. Ben Ryan, Dr. Rajiv Shah, Raul Salazar, and also I would like to thank the 996 participants who took part in this, this webinar. The PowerPoints will be available. The recording will also be available. And I will request Peter to give us the 2-day agenda, and we'll put it also along with the PowerPoint, because there have been many requests for that.
I'll be pleased to do that. Could I also just make one very quick point, Sanjay? Scorecards are really good at telling you where you're good and bad. They're not so good at telling you how to move forward. What I also have and will include with the agenda is an approach to figuring out how also to move forward, a structured way of thinking about creating a resilience agenda, if you will. It's part of that same presentation, so I'll be very happy to make that available.
Thank you. And we also hope that sometime in the future we might have a online course available, because these days face-to-face is not possible. So how to use the scorecard. So let's see about that. So with that, thank you again, everyone. And we close this webinar. Over.
Thank you.